In patients with severe sepsis, so nowadays phenotypes and endotypes are very commonly asked, so we should be aware of them. In patients with severe sepsis, which immunomodulatory endotype is most likely to benefit from corticosteroid therapy? The choices are hyperinflammatory, which is high cytokines phenotype with vasoplegia, immunoparalysis with low HLA-DR expression, low inflammatory phenotype with shock, and viral sepsis only. So the correct answer is hyperinflammatory phenotype, which has high cytokines with vasoplegia. So corticosteroids are most beneficial in septic shock with persistent vasoplegia, especially where excessive inflammation drives hypotension. And trials have shown that hydrocortisone shortens shock duration and may reduce vasopressor dependency. And in contrast, when the patient is having an immunoparalytic phenotype or endotype, it may not be benefited by steroids. So ideally, how are we trying to recognize? We are trying to use precision medicines and clinically bedside markers, a mix of them to identify the subphenotypes or endotypes to guide the steroid use. So here we can see a table of hyperinflammatory and immunoparalytic ones. So as the name suggests, reactive or hyperinflammatory, the cytokines are increased. The patient has neutrophilia, usually happens in early septic shock with high lactate and multi-organ dysfunction. The patient has high CRP, ferritin procalcitonin, and leukocytosis, and it is usually steroid responsive. When we talk about immunoparalytic one, the patient usually has a decrease in pro-inflammatory cytokines, lymphopenia. This happens usually in late sepsis or secondary infections like VAP or fungemia. And the patient usually has a normal or low CRP, lymphopenia, and low HLA-DR. The patient may benefit from immune stimulants, but usually steroids are not that effective. So we have to try and identify which is a subtype or endotype of the sepsis or septic shock that we are dealing with.